I'm Dr. John Morris. I'm an orthopedic surgeon from Ann Arbor, Michigan, home of the Big House. I've been in the private practice of orthopedics since 1978 and have been a clinical instructor at the University of Michigan in the Department of Orthopedic Surgery. Today we're going to talk about venous thromboembolic disease, or VTE, in total joints. Now, these clots begin on the venous side, which is low pressure and low flow. They begin around these little valve leaflets in the veins and are started by fibrin clots, which are then reinforced by platelets. These clots can then break off and travel up into the lungs and cause a pulmonary embolus. A large pulmonary embolus like this is called a saddle embolus and can result in virtually immediate death. Virchow's triad is used to describe the situations in which clots are increased. Venous stasis, or decreased blood flow, is very prominent in surgery, of course, when the patient's under anesthesia. There's also a hypercoagulability state induced by the surgical trauma. There's really minimal endothelial injury in the total joint population. The blood clotting cascade has an intrinsic and extrinsic pathway, which results in a final common pathway which promotes prothrombin going to thrombin, which catalyzes fibrinogen to fibrin, which then initiates the clots. Now, the pharmaceutical industry tries to intervene in various steps to block this cascade from occurring. The problem with anticoagulation is there can be a 5 to 10% complication rate from bleeding, resulting in wound hematomas, increased infection rates, GI bleeds, even death. Another problem with anticoagulation is that this is an elderly population. They may be on multiple other drugs, and then getting them to take the medications properly can be a chore. Aspirin can give a 25% VTE prophylaxis benefit through its antiplatelet effect. It's low cost, low morbidity, and is a good adjunct to intermittent pneumatic compression. Intermittent pneumatic compression reduces venous stasis, congestion, and swelling in the lower extremity. It also increases fibrinolytic activity. It's minimal morbidity, low cost, and highly effective when used properly. And it's the when used properly that's the important point here. So how did we get here? Sir John Charnley, back in the 60s and early 70s, reported on nearly 8,000 total hip arthroplasties done over in England. In his series, fatal pulmonary embolism rates were 1%, with non-fatal rates nearly 8%. On this side of the ocean, Dr. Coventry in 1974 reported on over 2,000 total hips. In his series, the pulmonary embolism rate was 2.2%. You can see that his surgeries took almost 2.5 hours with multiple units of blood loss, multiple transfusions. Warfarin was started 5 days post-op, bed rest for a week, and discharged 3 weeks post-op. So back in the day, pulmonologists became the VT experts. Anticoagulation became the standard treatment for pulmonary embolus, and then this was extended to VTE prophylaxis. A major problem was that the pulmonologist did not see the morbidity. If a patient was readmitted with a spinal cord bleed and paralysis, the pulmonologist was not consulted. However, the orthopedic surgeon who did the surgery was consulted. So over time, the American Academy of Orthopedic Surgeons came into conflict with the American College of Chest Physicians. So we had the classic problem of trying to describe what was going on by people from different vantage points or different perceptions. The American College of Chest Physicians felt that VTE was a serious life-threatening condition, that anticoagulation measures were justified. The treatment for pulmonary embolus was then extrapolated to the treatment for prophylaxis, which was anticoagulation. Many of these pulmonologists became pharma consultants, which created a conflict of interest. And again, we would stress that the pulmonologists were not directly involved with taking care of the complications. Over the last 10 to 20 years, the OR times have shortened down to 1 to 2 hours. Blood loss and transfusion rates have decreased markedly. Mobilization has been very rapid, with discharge either the same day or within 3 days in most cases. VTE prophylaxis, including intermittent pneumatic compression and some pharmaceutical agent, has become routine. Currently, the fatal pulmonary embolism rate is 1 in 1,000, with the symptomatic VTE rates being 1 to 2%. AAOS saw VTE as an occasional problem which usually self-corrected. Many felt anticoagulation morbidity was worse and more frequent than the VTE. Aspirin was felt to have some benefit and much less morbidity. Intermittent pneumatic compression was known to have some benefit. Therefore, the American Academy of Orthopedic Surgeons arrived at a recommendation for using intermittent pneumatic compression stockings and aspirin for VTE prophylaxis in normal risk patients. In 1991, Maynard et al. Reported that 86% of limbs eventually positive for DVT after a total knee were positive within 1 day post-operatively, and this was with venographic evidence. Camarado et al. In 1992 published a paper entitled, "Why Does Prophylaxis with Pneumatic Compression for Deep Vein Thrombosis Fail?" The take-home message there was compliance. Only 50% of patients on an average nursing unit actually had the stockings in place when the team went around. Previously published studies failed to recognize compliance as an issue, so prior to this 1992 study, the opinion was that intermittent pneumatic compression was helpful but not dependable enough to be the sole VTE prophylaxis. Hooker et al. In 1999 used bilateral intermittent pneumatic compression on total hip arthroplasty cases. The DVT rate went down to 4.6 versus 50% previously. The symptomatic pulmonary embolism rate was 0.6%. Westridge in 2000 did a meta-analysis of independent variables. Intermittent pneumatic compression was by far the most effective. Greenfield in 2001 failed to find any significant differences between different brands of intermittent pneumatic compression devices regarding multiple parameters. His conclusion was that compliance, ease of use, and timeliness were the critical factors. In 2012, the American College of Chest Physicians came to a landmark decision. Members who had a pharma conflict of interest were removed from their panel. With these members removed, the recommendations then included intermittent pneumatic compression and aspirin as an alternative for VTE prophylaxis for standard risk patients, anticoagulation not required. This then is quite similar to the American Academy of Orthopedic Surgery. In 2014, a multi-center study concluded that the use of a mobile compression device with or without aspirin for prophylaxis was a good alternative to pharmacologic prophylaxis in patients treated with arthroplasty of the lower extremity. The institutions included the Scripps Clinic, the Hospital for Special Surgery, and the Cleveland Clinic, among many institutions. So in 2016, the American Academy of Orthopedic Surgeons, the American College of Chest Physicians, and the Surgical Care Improvement Project dictate the standard of practice. Currently, all recommend intermittent pneumatic compression. All recommend post-hospital VTE prophylaxis after a total joint. All sanction intermittent pneumatic compression and aspirin in normal risk patients without anticoagulation. Aspirin alone is not enough in most people's opinion. In 2008, the United States Center for Medicare and Medicaid Services came up with the concept of a never event. VTE has now been declared a never event. So if people are readmitted with VTEs, there are payment implications and quality of care implications. In 2010, there were over 500,000 total knees done and over 200,000 total hips done. These numbers are expected to balloon by 2030, such that 3.5 million total knees are expected to be done in 2030 and over 500,000 total hips. Up to 90% of elective total joints may be eligible for aspirin and IPC, including home IPC following discharge. In our current market, insurance coverage for home IPC is now about 50%. Medicare has not yet approved this for DVT prophylaxis. There are some unscrupulous vendors trying to bill out lymphedema codes and arterial insufficiency codes, which amounts to fraud. My current VTE protocol for total knees involves placing an intermittent pneumatic compression device on the opposite side during the entire case, which gives about a 10% benefit. a sterile IPC on the same side after tourniquet deflation, and then intermittent pneumatic compression on both sides in the recovery room as much as possible on the floor. This is then continued 2 weeks post-op, while at home at least 20 hours a day. Aspirin is used for 6 weeks. We encourage active ankle exercises and early mobilization. The protocol for total hips is similar. Bilateral intermittent pneumatic compression during the entire case and in recovery room. Intermittent pneumatic compression as much as possible on the floor. IPC for 2 weeks post-op, ankle exercises, mobilization, and aspirin for 6 weeks post-op. In the past, surgeons have been threatened with lawsuits because they didn't do prophylaxis and didn't put patients on blood thinners. Now the tables have turned, and the trial lawyers are going after Xarelto and multiple other of the newer anticoagulation medications because of complications. Xarelto and apixaban are factor Xa inhibitors. These are not reversible, which is a problem. Also, if a dose is missed, the patient becomes susceptible to clots. Pradaxa is a thrombin inhibitor. It's now reversible with Praxbind. A missed dose, however, results in no protection. There has been a $650 million settlement over in Europe to settle 4,000 Pradaxa claims. This is an article which I co-authored in Orthopedics in December of 2012, which has many of the references that we've referred to. Thank you for your attention.